Sarah, is everything okay?
Yes.
Hannah, can you? Okay, right, fine, good. Right, just there are some people still joining. We'll just wait for a few minutes. It's fine.
Okay.
Okay, right. Okay, fine. So let's get started. Right. So today, okay, right. Right, fine. So today we're going to discuss that we have, as I told you, we have 2 sessions on neurology. So we start off today's session with the cranial nerves, and then tomorrow we move on to the limb examination. I split this up into 2 purposefully because we need to take this a little bit slowly. It's too much material to discuss this in one day. Okay, fine. So let's start off with the cranial nerves, and this will follow a similar structure to most of the other sessions that we have had so far. And initially, I will talk about the important techniques in examination and the examination routine, and then we'll move on to interpretation of physical signs. Hari. Good. Right now, if you take the cranial nerves, the first cranial nerve, we routinely don't examine this, so don't worry about it too much. Now, when it comes to the optic nerve, there are several components of the optic nerve examination. Okay, and in your examination, you are supposed to carry out all of these components. Now, the optic nerve examination commences with examination of visual acuity. Now, remember, you cannot do anything else without starting with the visual acuity. If the patient can't see, then there's no point in proceeding. So the visual acuity is measured or checked with a Pocket-Stellen's chart. So when you go to clinicals, make sure that you buy a Pocket-Stellen's chart and use the Pocket-Stellen's chart. Fine. Now, this is a particularly important examination technique within the optic nerve, and that is the second cranial nerve, and this is examination of the visual fields. Now, for examination of the visual fields, please take note of this very, very carefully. Examination of the visual fields, we use a technique called the confrontation method. Now, there are certain key things in this technique that you should follow, and just look at the pictures that I have demonstrated, this picture, and there are subsequent pictures as well, which demonstrate the proper technique. So let's go through the elements of a proper technique of how to examine the visual fields. And we use this called the confrontation method. So if you have to write this down and practice this when you go to the wards, number 1 is that you have to stand directly in front of the patient. That is the first thing that you have to do, right? Stand directly in front of the patient. The second thing you need to do is you need to come down to the same eye level. So stand directly in front of the patient's face. Your face and the patient's face should be directly in front of each other, and go down to the eye level. So same eye level, patient's eye level and your eye level should be the same. Fine. That's done. Then you need to bring your finger in from the side, okay, from this side in 4 quadrants, 1, 2, 3, and 4, and check each eye separately while covering the other eye, as you can see. So stand directly in front of the patient, come to the same eye level, use your finger to assess the quadrants, that is the temporal and the nasal fields for each eye. Now, what's the other pictures that I have given you here? You can see that, again, same eye level, right in front of the patient. And your finger, now this is the next important point, so mark this down again, should come midpoint between yourself and the patient. So the finger should come midpoint between yourself and the patient. Okay, that is very, very important. And maintain that distance. Don't bring it too close to the patient. Don't bring it too close to yourself, because all these can alter your findings. All these things can alter your findings. So midline, midway between yourself and the patient. Don't bring your finger too close to the patient. Don't bring it too close to yourself. These are some important principles that you need to stick to when you're doing this examination. Now watch again in the next few pictures. Again, I have shown you the other eye. You can see again, I'm adhering this very important principle, same eye level, right? Directly in front of the patient, and my finger is right at the middle, in the midline between yourself and the patient. And I am not changing that distance. The finger is coming through in the same distance, right? Same distance. That is very, very important. And we examine these 4 quadrants, the temporal and the nasal field, on each eye separately, right? And make sure that you cover your corresponding eye. So these are some important principles when it comes to visual field examination. Oops, sorry. Okay. Now, optic nerve, so therefore you have visual acuity, visual field examination. Then so visual field again, directly in front, your eye level, patient's eye level, bring your finger midway between yourself and the patient and maintain that distance throughout that range of motion. Follow the 4 quadrants for each eye. Close your corresponding eye. Important principles there. Okay. Now the next few things in the optic nerve are the pupillary reflexes. And pupillary reflexes, again demonstrating the pupillary light reflex. Okay. Very important reflex that you need to examine, the light reflex. Okay, light reflex. And again, observe the pictures. When you are doing the light reflex, stand slightly to the side of the patient. Don't stand right in front of the patient. So pupillary reflex, light reflex. And also there is another reflex which is less important, I would say, but you still need to do it, which is the accommodation reflex, which somebody will show you how to do when you go to your clinical appointments. Okay. So pupil reflexes, light reflex, and accommodation reflex. Color vision we don't routinely examine. Fundus is another different technique of examination. Again, somebody will teach this to you in your appointments, how to examine the fundus in the proper technique. So that's the second nerve. So what are the components of the second cranial nerve then? Acuity, fields, the reflexes, the direct and consensual light reflex, okay? And then the fundus we do not, we examine, but it's a different technique which somebody will teach you. Color vision is not routinely examined. Then we go on to 3, 4, and 6. Why do we examine these cranial nerves together? Because they examine the extraocular muscles of the eyeball, okay? And then you move your finger in the shape of a H, okay? Move your finger in the shape of a H, examining the eye movements and the extraocular muscles, 3, 4, and 6. And you know that most of the eye movements are managed or controlled with the oculomotor nerve, right? The 4th nerve supplies superior oblique, and the 6th nerve supplies the lateral rectus. This is basic anatomy that you need to remember, right? So make sure that you move your finger in the direction of a H, or the movement should be in the shape of an H. So that is 3, 4, and 6. Moving on to the trigeminal nerve. So trigeminal nerves is a rather large complex nerve. There is a motor component and a sensory component, okay? Motor component and sensory component. This is the motor component where you are examining the muscles of mastication, which is the temporalis muscle, okay, there, and the masseters there, asking the patient to clench the teeth. Opening of the mouth against resistance is with the lateral pterygoid muscle. Lateral pterygoid muscle. The jaw reflex again is an important reflex which is innervated partly by the trigeminal nerve. Now, important things when you're doing the jaw reflex is this: the patient's mouth should be open and your tendon hammer should strike at a 90-degree, write this down, at a 90-degree angle to the masseter. It should strike down at a 90-degree angle to the masseter muscle. Okay? And it's better if you can ask the patient to close the eyes when you're doing this, because sometimes the jaw suddenly closes. The jaw reflex is usually not present. It's very, very difficult to elicit in a normal person. So if you actually get the jaw reflex, that means it is pathological. It is pathological. We'll talk about the jaw reflex later, right? So the jaw reflex is something that you need to do very, very carefully. 90-degree angle, strike at 90-degree angle for the masseter muscle and observe the closing of the jaw. If you get the reflex, that is a pathological response, because usually you don't get the reflex. The sensory component of the trigeminal nerve, I have given you a picture with all these, with the distribution. And remember two things, I might have taught this to you. The ophthalmic sensation extends right up to the vertex of the skull there, okay? That is one important point about the trigeminal nerve sensory distribution. And always remember, the angle of the mandible is not, underline the word, not supplied by the trigeminal nerves. The angle of the mandible there is not supplied by the trigeminal nerve. It is supplied by the greater auricular nerve, which is coming from your cervical nerves, cervical nerve roots. So this area, the angle of the jaw is not supplied by the trigeminal nerve. So these are two important things that you will need in your examination routine. So trigeminal motor sensory. Then you have the facial nerve, and you know that the facial nerve, you have to examine the muscles of facial expression. Okay, wrinkling of the forehead, clenching of the eyes, and the platysma. So these things you need to examine as muscles of facial expression. The facial nerve also supplies other key things like taste, and there's also innervation in the ear, nerve to stapedius, but those are not really routinely examined in your bedside examination. The eighth cranial nerve ideally should be examined by the Renes test and Weber test. You have been taught this in physiology, so just revise that. As a rough screening examination at a bedside, if you don't have a tuning fork to do the Renes and the Webers, you can use this whisper test, where you whisper something into the ear and ask the patient to repeat that. Important things when you're doing this is make sure the patient's face is turned to the other side, and you mask. You can see my right hand is masking the opposite ear, so that the patient does not hear from that side. Okay, from that side. So head turned to the opposite side, the other ear being masked, and then you whisper something into the ear. So this is the whisper test. It is a screening examination. The proper way you do this is with a Renes and a Weber's test. So 7 muscles of facial expression, 8 is the whisper test. Now remember that the 8th cranial nerve also has a vestibular component which is not routinely examined. Okay. Now we are left with 9, 10, 11 and 12, which are the lower cranial nerves. Now of these, 9 and 10 supply the palatal region. So you know this, open the mouth, look at the position of the uvula and whether it deviates to any side. Okay, when the patient says ah. Okay. And then this is the accessory nerve, the sternocleidomastoid muscle there. Remember, make sure that you examine the proper side. Okay, so when you ask the patient look to the left, the patient is using the opposite side sternocleidomastoid. Right? I forgot to talk about the trigeminal, the glossopharyngeal nerve, the hypoglossal nerve. And there you ask the patient to protrude the tongue and then look for any deviation of the tongue to either side. So that's basically how you look at the hypoglossal nerve. Accessory nerve, I have just explained how you examine for that. Right? Turn the head to a side. and then look at the bulk of the sternocleidomastoid. Make sure that you examine the proper side. Very, very hard. So that is basically the technique. And I'll just run through this again with you. So olfactory routinely not examined. Optic nerve, first component is visual acuity. Make sure that you do the visual fields with the proper technique, right? Don't miss any steps that I have described, because you will get wrong findings if you do it wrong, okay? Optic nerve, make sure that you have the pupillary reflexes, color vision not routinely examined, and then the fundus as well, okay? Okay, then eye movements, shape of H. Trigeminal nerve, look at the muscles of mastication. Sensory and the jaw reflex. Sensory, remember that the ophthalmic division extends right up to the vertex of the skull. Facial nerve, you are looking for muscles of facial expression. Eighth cranial nerve, ideally Rene Weber, but if you don't have a tuning fork, you can use the whisper test and check the hearing on both sides. It is a bedside screening test for hearing. Lower cranial nerves, 9, 10, and 12, you are looking at palatal movement, tongue movement. Accessory nerve, make sure that you look at the proper side. Proper side. Harine, okay. Okay, now we come to the important part. And this is new to you. So be careful and listen very, very, very carefully to this. Now, when you talk about interpretation of physical signs in neurology, in your neurology module, which is fantastically done by the way, you would have obviously been taught about how to interpret neurological lesions, right? So, neurology, there are two questions. Professor Chang would have obviously taught you about this. You have to first discuss where the lesion is. Now, where the lesion means, it is localization. So, localization is where in the nervous system is this lesion? Is it in the brainstem? Is it in the muscle or spinal cord or whatever? Right? Localization. Lateralization means whether it's on the left side or the right side. So the question where is the lesion has two subcomponents that you need to answer. One is localization, where exactly the lesion is in the nervous system. And then lateralization means what side, is it left or right? And with your examination, you should be able to answer this question perfectly. The next question is what is the lesion? And that is the etiology or pathology of the lesion. Whether it's an infection, whether it's an inflammatory disease, whether it's a degenerative disease or a vascular disease, these are all pathologies. But remember that some of them can be addressed with the examination, but some of them you need the history as well. So you maybe won't be able to identify all the pathologies with your examination. So of the two questions, the first question you can identify very, very simply with your examination if you know your basic stuff. So now let's start to put this into practice, right? And just revise a bit of your neurology module that you have been taught. And I know that neurology module is mostly theoretical, but now we'll try to put this into practice in your clinical practice, in your second appointment, professorial appointment and beyond. Okay, fine. Good. So we start off with the second cranial nerve. Now in the second cranial nerve, what you are going to encounter is going to be visual field defects. So you will get visual field defects for your exam. Okay, visual field defects. Remember, there are a whole range of visual field defects, but there are only two important ones for undergraduates. Right. The first one is B. So if you look at this diagram very carefully, B is the first one you need to know as an undergraduate medical student, right? A visual field defect that you have to know as an undergraduate medical student. And this is bitemporal hemianopia. Bitemporal hemianopia, where the patient cannot see the two sides, the temporal sides of the visual field. This is called bitemporal hemianopia. Bitemporal hemianopia. And the lesion, so first question, where is the lesion? The lesion is always in the optic chiasmal region. You can see that B marked in the main image there. That is where we are focusing on. So right in the middle of the optic chiasma, right in the middle of the optic chiasma. The lesion is exactly there, nowhere else. Harida, where is the lesion? What is the lesion? The etiology most often is due to compression due to a pituitary tumor. Most often. There are some exceptions, but most often this is due to pituitary tumor pressing on the optic chiasma. Because the pituitary gland is in very, very close relationship with this area. Very, very close. Okay. So remember that. Bitemporal hemianopia, optic chiasma lesion. That's the first thing you need to know as a medical student. Second thing you need to know is this. This is homonymous hemianopia. Homonymous hemianopia. Where one side, either left or right, cannot be seen. Right? Homonymous hemianopia. And as a medical student, you need to know two things about this. Any lesion distal to the optic chiasma. So you have the optic tract, optic radiation, and the occipital cortex. So any point distal, any point distal to the optic chiasma, that is the optic tract, the optic radiation, which is mentioned as D, and E, which is the occipital cortex. The lesion can be anywhere in these three places: tract, radiation, and cortex. Now you can actually differentiate these three as well, Harida, but as again undergraduate medical student, you don't need to know how to do that. Where is the lesion in a homonymous hemianopia? The only answer that you have to give is it is distal to the optic chiasma. It could be in the tract, optic radiation, or in the occipital cortex. Eka kiyala but the most common lesion we find is in the optic cortex. Most often E tamai commonly apita peenna tiyenna. Okay, E. Right? So the most often the lesion is E or sometimes D as well. So, but definitely more commonly in E when you get homonymous hemianopia. So most often clinically you will find the lesion in E, in the occipital cortex. So can be distal to the optic chiasma, most often or commonly in the optic cortex. Harine, right. Now write the next thing also down. There is one more thing you need to know about homonymous hemianopia as a medical student. Now, if you take the occipital cortical lesions, commonest cause of homonymous hemianopia, commonest area that is involved in homonymous hemianopia is the occipital cortex. A little more about that. Right. If you take the optical cortex or the occipital lobe, there are two types of lesions. Number one, a vascular lesion or an infarction of the occipital cortex. The other one is a destructive process in the occipital cortex, for it, like a tumor, for example. A tumor, a destructive lesion in the occipital cortex. These two are different. Why? In a vascular lesion of the occipital cortex, the macula is spared. In a vascular lesion of the occipital cortex, the macula is spared. Why? Because the occipital cortex is mainly supplied by the posterior cerebral artery, but the macula is supplied by the middle cerebral artery. In a vascular lesion of the posterior cerebral artery, they get an infarct of the occipital cortex, but the macula is spared. Why is the macula spared? Because it is supplied by the middle cerebral artery. It's a completely different blood supply. So if it's a vascular lesion or infarction in this area, they will get macula sparing. My tumor is different. Tumor doesn't have vascular orientation. It destroys the whole occipital cortex. In that instance, the macula will be involved. And that is called macular splitting. SPLITTING. Macular splitting. homonymous hemianopia. So homonymous hemianopia is a lesion distal to the optic chiasm. This could be in the optic tract, optic radiation, or occipital cortex, but most commonly in the occipital cortex. There are two types of lesions in the occipital cortex: a vascular lesion of the posterior cerebral artery causing an infarction, or a tumor in the occipital cortex. We know that the middle cerebral artery supplies the macula. So in a vascular lesion, there is macular sparing. But a tumor does not follow these vascular land boundaries. It involves a whole bloody thing. So macula will be involved. Okay? So that's basically what you need to do. ඔය ටික තමයි visual field defects ගැන දැනගන්න තියෙන්නේ. Fine, darling.
It's got white ball.
Right, we'll come. I'll come. Okay. Okay. Hi. Moving on. Now, if you move on to the rest of the cranial nerves, another common problem you will see in your examination of the cranial nerves is ptosis. Ptosis. I'll talk a little bit about ptosis, but then we'll move on quickly. Right? Now, ptosis is due to a weakness of a particular muscle.
Muscle?
Yeah. What is that muscle? The muscle is the levator palpebrae superioris muscle. Okay, so you have the levator palpebrae superioris muscle. So weakness of this muscle will cause ptosis. The levator palpebrae superioris muscle has a dual supply. Most of the supply is by the third cranial nerve. Third cranial nerve supplies most of the components of that muscle. Right? A little bit of it is supplied by the sympathetic nerve. The sympathetic nerve. Okay, so a little smooth muscle component is supplied by the sympathetic nerve. So that's a two innervations. So then we know that ptosis could be due to a disorder in the third nerve or its pathway. Third nerve or its pathway. Okay, third nerve or its pathway. Third nerve pathway also muscle and neuromuscular junction. Okay, muscle and neuromuscular junction. Okay, so third nerve pathway includes the muscle and the neuromuscular junction also. Okay. The ptosis is basically either due to a third nerve lesion or a lesion of the sympathetic nervous system. Okay, sympathetic nerve supply. So third nerve, third nerve lesion could be in the third nerve itself along the pathway, or in the muscle, or in the neuromuscular junction. Okay. And we will teach you a little bit more about ptosis when you start your professorial appointments. Okay. Danata eka thama chuttak badi, but we'll teach this to you when you come to your professorial appointments. Okay. Good. So at the moment you need to know, ptosis can be due to lesions in the third nerve or its pathway, which include the neuromuscular junction and the muscle, or it could be a lesion in the sympathetic nervous system. That's all you need to know. Hi, now we move on to the third nerve. Just give me a second. Baba, can you go and play, Charlie? Hi. Okay. Right. Okay. So third cranial nerve. Okay. Now in this picture, you will be able to see a patient with a third cranial nerve palsy. Okay. Third cranial nerve palsy on the left side. Why do I say it's a third cranial nerve palsy? Because there is complete ptosis of the left side. Okay. Complete ptosis of the left side. And the other thing you can see in this picture is that the eyeball is deviated laterally and downwards. Laterally and downwards. Why is it shifted laterally and downwards? Because when the third cranial nerve is involved, okay, the only muscles that are remaining now are the lateral rectus, which pulls the eyeball laterally, and the superior oblique, which pulls it down. So these are the only two muscles that are remaining. And you know that in a third cranial nerve palsy, you get complete ptosis because of, as just a little while ago I mentioned, that it supplies the levator palpebrae superioris muscle. Okay? And then the eyeball is pulled laterally and downwards. Laterally, why? Because of the lateral rectus pull action, and downwards because of the superior oblique action. Now, once you identify a third cranial nerve palsy, Lamai, you have to say where along the pathway the lesion is. And please, when I finish this class, go back to your neuroanatomy and your whatever head and neck notes and write the pathway of the third nerve. That you have to know for medicine, right? You have to know the pathway of the third nerve. And I will just quickly revise that as we go on. The third nerve starts in the midbrain, as you know. Then බලන්න මම මේක සම්බන්ධ කරන හැටි. If there is a lesion in the midbrain causing a third nerve palsy, and this is, so the third nerve nucleus is somewhere in this region, okay, in this region. Okay, and let's watch my mouse point again. So that is the third nerve nucleus. If the third nerve is involved due to a midbrain lesion, what are you going to expect? And we are trying now to localize it. So imagine you had this patient. You find very clearly a third nerve palsy. Why? Complete ptosis plus this eyeball laterally and downwards. Then අපි කරන්න හදන්නේ මොකද්ද? We are trying to pinpoint where about in this long course the lesion is. So we start right at the top at the midbrain. So imagine if it's a midbrain lesion, what is going to happen? What is going to happen is the third nerve is going to go with some other structures. One of the other important structures is the corticospinal tract. Corticospinal tract, which travels somewhere around in this region. And therefore, what do you get? Hemiparesis. Same side or other side? It is the other side. Because why? This is basic neuroanatomy. The corticospinal tract crosses in the medulla. So the corticospinal tract in this area, in your midbrain, supplies the opposite side of your body. So if your lesion was in the midbrain, you get a third nerve palsy plus a weakness or hemiparesis on the other side. Contralateral hemiparesis. Harida. There are also other structures in the midbrain, like the cerebellar pathways, and something called this big bole in the middle, which is called the red nucleus. These structures can be damaged as well, and they cause ipsilateral signs. So cerebellar disorders, red nucleus damage causes ipsilateral signs. Ipsilaterals. So they get cerebellar signs, and red nucleus lesions cause a very coarse tremor. Very coarse tremor, red nucleus. So very important, we are trying now to localize the site of lesion in this particular patient who has a third nerve palsy. And what we are going to talk about is midbrain. If it is in the midbrain, you will get contralateral hemiparesis because of the damage to the corticospinal tract, which is uncrossed, and it is going on to the other side of the body, crossing lower down in the medulla. We'll also get damage to the cerebellar pathways and the red nucleus, which causes ipsilateral or same side signs. In this patient, දකුණු පැත්තේ weakness එකක් තිබුණා. If there was hemiparesis on the right, we know, right, patas, the lesion is in the midbrain. Magic වගේ, you know that. Hari. What happens to the third cranial nerve after this? You see this, the third cranial nerve goes out of the midbrain and crosses very close to this particular artery here. So that's the third nerve, and very close to this artery, which is called the posterior communicating artery. An aneurysm of the posterior communicating artery can cause the third nerve compression. You can see this in this picture on the top left, right? So that is a compressive lesion of the third nerve. So what happens is the third nerve palsy occurs like this. And another thing happens, can you see this guy's pupil is large? The pupil is dilated because what happens? When there is a compression of the third nerve, the pupillary fibers of the third nerve, which travel on the outermost aspect, are compressed. So therefore, this gives rise to pupillary dilatation, like in this patient here, pupillary dilatation. Okay, good. So midbrain, third nerve plus contralateral hemiparesis or ipsilateral cerebellar signs or a coarse tremor or a red nucleus. It's called rubral tremor. Rubral can ratu, red nucleus. If it is a lesion in the posterior communicating artery territory, you get an isolated third nerve palsy with a dilated pupil because that travels very close to the third nerve. Okay. Another cause of isolated third nerve palsy is diabetes and hypertension. This was also called a medical third nerve palsy. So isolated third nerve palsy can also be due to diabetes and hypertension. The main difference with a PCOM aneurysm causing a third nerve palsy is diabetes and hypertension. The nerve is involved from inside out. So the pupils are spared. And this picture on the right side, right lower aspect of your slide will show you the difference between that. Diabetes, hypertension, the nerve is involved from in out. So the pupil is not involved. If it's an aneurysmal compression of the third nerve, then the pupil is involved because why? The pupillary fibers travel on the outermost aspect of the third nerve. Ekai me. Harine, right. Moving on. ඊගාවට මොකද වෙන්නේ? Then the third nerve travels into the cavernous sinus. You can see this area there, which is the cavernous sinus. In the cavernous sinus, 3, 4, 6, 3, 4, 6, and the first and second divisions of the trigeminal nerve, they travel in close proximity. So, what will you get if there is a lesion in the cavernous sinus? No. So that you call complete ophthalmoplegia. Eyeball doesn't move in any direction. Why? 3, 4, 6, all the 3 cranial nerves are gone. So the eyeball does not move in either direction. It is completely ophthalmoplegic. Completely ophthalmoplegic. In addition, what are you going to get? Now remember, in the cavernous sinus, ophthalmic and maxillary divisions were there. Because they are involved, what are you going to get? Sensory loss. They are in the ophthalmic division, that area, and the maxillary division. Sensory loss. If it's thrombosis of the cavernous sinus, the eyeball will be swollen and red. Right? Proptosis, pushed forward, swollen and red. That is cavernous sinus thrombosis. Thavapodi point in cavernous sinus thrombosis, you might get bilateral signs. What is the reason for that? In the second picture, you see that. Why? Because it communicates to the other side. So sometimes you get bilateral signs. Bilateral signs. Exam and in any third nerve case that you encounter, they are going to ask this. Okay. So remember, third nerve arises at the midbrain. Lesion in the midbrain will cause damage to corticospinal tracts, red nucleus, and cerebellar fibers. So you get contralateral hemiparesis, ipsilateral cerebellar signs, or red nuclear tremor. The third nerve next goes to the closer to the posterior communicating artery. Aneurysms can cause compression there, and then that can cause isolated underline isolated third nerve pulse with pupillary involved, because the pupillary fibers are the outermost aspect of the third nerve. Isolated third nerve palsy can also be due to medical causes like diabetes and hypertension. But there the disease is Madet to Elliott. So the pupils are usually spared in that condition. The third cranial nerve next travels through the cavernous sinus. There you have 3, 4, and 6 together, and the first and second divisions of the trigeminal nerve. So lesion there would cause complete ophthalmoplegia with sensory loss in the ophthalmic and maxillary division. If it's a thrombosis of the cavernous sinus, eyeball will be propped towards keymost and very painful and red. Right, good. Moving on. The oculomotor nerve then travels into the superior orbital fissure. මතකයි නේද මේ superior orbital fissure කියන එක මෙන්න මෙතන. In the superior orbital fissure, what are the cranial nerves? 3, 4, 6, and the first, that is ophthalmic division of the trigeminal nerve. Ophthalmic division of the trigeminal nerve. Maxillary division has gone out. It has gone out. So if you have a superior orbital fissure lesion, it is going to be exactly the same like a cavernous sinus lesion. The only difference is the sensory loss is only in the ophthalmic division. Only in the ophthalmic division. Right. Finally, the third nerve goes through or very closely to the orbital apex, that is somewhere here. So methanic avilla, it goes into the orbital apex. In the orbital apex, what are the nerves which are close together? Third, fourth, sixth, because they are still going into the ocular muscles. Third, fourth, and sixth. The trigeminal nerve has gone away. There is no trigeminal nerve anymore. What is the nerve which is in close relationship? It is the optic nerve. Optic nerve. Optic nerve. So if it is a lesion in the orbital apex, somewhere there, you get again complete ophthalmoplegia because 3, 4, 6 all are gone. And what is the thing you are going to get? Low visual acuity on the side. Low visual acuity. Then balanna. Now I'm going to revise this with you. Third nerve, you diagnose it. Fine. Katandare ivara naha. You need to localize it. How do you localize it? Could this, you ask yourself, could this be the midbrain? If it is in the midbrain, you should have contralateral hemiparesis or ipsilateral cerebellar signs or red nuclear tremor or some odd thing like that. Brainstem signs. If it's an isolated thing, it could be a PCOM aneurysm, but then you are looking for dilated pupil. If dilated pupil එකක් නැතුව නිකම්ම third nerve pulse එකක් තියෙනවා නම් විතරක්, then you know it is probably diabetes or hypertension or some medical cause of a mononeuropathy. The third nerve next goes into the cavernous sinus. 3, 4, 6 are together with the ophthalmic and maxillary divisions of the trigeminal nerve. So if it's a lesion there, you get all of those involved. If it's a lesion in the superior orbital fissure right there, then 3, 4, 6 and only the ophthalmic branch of the trigeminal nerve involved. Finally, it enters the orbital apex, where orbital apex, you have the optic nerve and the 3 nerves together. So you get 3, 4, 6 involved with loss of visual acuity or reduction of visual acuity if it's an orbital apex lesion. Now, okay, ලස්සන්ට ලියාගෙන third nerve එක පාඩම් කරගන්න because you need to know that. And any questions, please post it on the chat. Right. We move on to the 6th nerve now. All of you probably would have seen a 6th nerve palsy. This image is nice. It shows you a very obvious 6th nerve palsy where the eyeball is pulled medially. Why is it pulled medially? Because the lateral rectus is no longer working. Again, ara wagema lamai, you need to ask yourself, where in the pathway is this lesion, right? Just saying it's a 6th nerve palsy is not going to help your cause. You need to tell us where the lesion is. Again, very, very simple. The 6th nerve starts in the pons. So 3rd nerve in the midbrain, 6th nerve in the pons. In the pons, it is very close to the facial nerve nucleus. Facial nerve nucleus. The facial colliculus again, that is the area overlying the facial nerve nucleus. And also, like in the midbrain, you get the corticospinal tracts. Then if it is a pontine lesion, like hitan, use your brains. If it's a pontine lesion, in the nucleus of the sixth nerve, what is going to be in addition? The facial nerve nucleus is going to get involved on the same side. So you get a facial nerve nucleus. That is a lower motor neuron facial nerve pulse on the same side. Okay. And then because the corticospinal tracts are involved, you are going to get hemiparesis on the opposite side. Why opposite side? Because the pathway is still not crossed. It's still not crossed. It crosses lower down. Cross. So contralateral hemiparesis, sixth nerve palsy, seventh nerve palsy. Simple. Right. Then ඊතුරු ටික බලා ගන්න. The abducent nerve then follows a long intracranial course. And you know that increased intracranial pressure can cause isolated pressure on the sixth nerve. So that is a cause of isolated sixth nerve pulse. Because it's a long intracranial course, it gets involved because of the pressure coming from the increased intracranial pressure. So isolated sixth nerve palsy can be due to increased intracranial pressure. Write that down, very important. And isolated sixth nerve palsy can also be due to diabetes, hypertension, like a third nerve. Then the sixth nerve crosses very close to the apex. This is the petrous temporal bone. This is the apex of the petrous temporal bone. It crosses very close to that point. At that point, it is closely related to the fifth nerve. Hayai pahai ekalanga thiyen. Hayai pahai ekalanga thiyen. Petrous temporal bone. 6 and 5. Really, inflammation at the petrous temporal bone can cause sixth nerve palsy and fifth nerve palsy. Find out for homework what that syndrome is called. Inflammation of the apex of the petrous temporal bone causes sixth nerve palsy and fifth nerve. So to summarize up to now, the sixth nerve arises in the pons at the facial colliculus, very, very close to the facial nerve nucleus and the motor pathways going down. So lesion there would cause sixth, seventh, and a contralateral hemiparesis. It has a long intracranial course. Increased intracranial pressure can cause sixth nerve palsy and can things like diabetes and so on as well. The sixth nerve crosses very close to the apex of the petrous temporal bone and can be compressed at that point. And close to that point is also the fifth nerve. So you get sixth and fifth going together. Etanin ehata lamai is very easy because it's like there are makka rachane wage, because then you have the cavernous sinus. We already discussed this. Then the superior orbital fissure, and then that's it. Orbital apex, and that's it. So we already discussed lesions in these three areas: cavernous sinus, superior orbital fissure, orbital apex. Mankiwa thunedima complete ophthalmoplegia because all the three nerves are gone. But you can differentiate based on the trigeminal nerve sensory loss. If it's in the cavernous sinus, ophthalmic and maxillary. If it's in the superior orbital fissure, just the ophthalmic. If it's in the orbital apex, no trigeminal sensory loss, just the visual acuity reduction would be obvious. Right. So that is the sixth cranial nerve. Sixth cranial nerve. Right. Okay. That is the sixth cranial nerve. This is again a simplified pathway of the sixth cranial nerve. Seventh cranial nerve, facial nerve. Okay. Then you should know the course of the third cranial nerve. You should know the course of the sixth cranial nerve, because you can't work any of this out without knowing it. I have taught you this, but you need to know this now. Okay. And then now you also have to know the seventh cranial nerve. For neurology, you need to know these three cranial nerves, the course of these three cranial nerves. You have to know for your neurology appointments, obviously your medicine and professorial appointments, and your final exam. Then facial nerve supplies the muscles of facial expression. Now, facial nerve palsy can be upper motor neuron type, because not only the facial nerve, any cranial nerve gets an upper motor neuron innervation from the cortex. So all these cranial nerves, including the facial nerve, gets an upper motor neuron innervation. But and there can be lesions in those, but those are postgraduate stuff. So I didn't teach those to you. But remember, each cranial nerve nucleus has an upper motor neuron innervation. That is something that you need to remember. So in a facial nerve palsy, it could be upper motor neuron type or lower motor neuron type. That's the first thing. So if you feel facial nerve palsy, the first step is ask yourself the question, could this be lower motor neuron type or upper motor neuron type? And from your neuroanatomy days, third term in your first year, I think you still do it in your third term, you have been taught this, you have been asked this for as essay questions, SCQ questions, or it is a very famous thing that they teach in neuroanatomy. How to differentiate between upper motor neuron and lower motor and what the basis of that is. And this picture summarizes that beautifully. So please revise that. Okay. In upper motor neuron facial nerve palsy, only the lower part of the face is affected. Why is the upper part spared? Because it gets a dual innervation. You get an innervation. So dual innervation. So even though one innervation is gone, the upper part of the face still has another innervation intact. Lower part of the face only gets from one side. These upper motor neurons only come from one side. So upper motor neuron, lower motor neuron. Right. If it's a lower motor neuron facial nerve palsy, then you need to localize it to this place. We have already discussed facial nerve koheda patan gannawa kiwe pons එකේ. And you know that a lesion in the pons can cause a lower motor neuron type facial nerve palsy, very, very importantly. And අපි දැනටමත් එක්ක කතා කරලා තියෙනවා නේද? It also causes, what does it cause? Sixth nerve palsy. And it also causes maybe contracted hemiparesis and some cerebellar signs on the same side, because there are cerebellar connections. So pontine lesion can cause lower motor neuron facial nerve palsy. If it is a pontine lesion, then you're either going to get hemiparesis, a sixth nerve palsy on that same side. Then the facial nerve exits the brainstem and enters some place called the CP angle. In this CT scan is shown a tumor in that area. Then balanna CP angle කියන එකේ තියෙන nerves මොනවද කියලා. The fifth nerve is in the CP angle. This is called cerebellopontine angle. Right? CP angle, fifth nerve, seventh nerve, eighth nerve, and lower down you have the 9, 10, and so on. But the closest nerves are 8 and 5. Very, very important. So write this down. Sixth nerve is not. Sixth nerve is not in the CP angle. It goes anteriorly. Not in the CP angle. CP angle TNA 5th and 8th and 7th. So if there's a lesion of the facial nerve in the CP angle, then monodayana nerves 5, 7, and 8. In fact, the earliest sign is loss of corneal reflex, which is a trigeminal nerve innervated reflex. Okay, at least afferents are from the trigeminal nerve. Corneal reflex is the first thing to go actually. So CP angle 5, 7, 8. Then the 7th and 8th cranial nerve enter the facial canals. And in the facial canal, it goes very close to the ear structures. And a lesion in this area can cause 7 and 8 nerve palsy. Within the facial nerve canal, it gives off the geniculate ganglion and nerve to stapedius and nerve to cauda tympani. මේ බලන්න මේ picture එකේ nerve to stapedius, nerve to cauda tympani. So those nerves can be affected if it's a facial canal lesion, depending on the place. Depending on the place. Right. May hari. The place. So if it's gone somewhere there, these two will be involved. If the nerve lesion is somewhere here, then the cauda tympani and nerve to stapedius will be preserved. So based on the place where the lesion is within the facial canal and this bone, which is called the petrous temporal bone, the nerve to stapedius and cauda tympani can be variably affected. Then මොකද වෙන්නේ ඔය facial nerve එක එළියට එනවා during through this small hole which is called the stylomastoid foramen. Inflammation within the stylomastoid foramen causes Bell's palsy. And I hope all of you buggers know how Bell's palsy, how the name Bell's palsy came by. Right? Find out. It's interesting to read. So Bell's palsy is an inflammation at the stylomastoid foramen. එතනින් එහාට අපි දන්නවා the facial nerve branches out and enters the parotid gland. So tumors in the parotid gland can cause facial nerve palsy. What is this? The next picture is an interesting lesion, facial nerve palsy, and what are these? There are small vesicles inside the ear. What is that due to? That is due to Ramsay-Hunt syndrome, or this is herpes zoster of the geniculate ganglia. Herpes zoster of the geniculate ganglia. Hi. Then ahaganai. Seventh nerve. How do you localize a seventh nerve palsy? What is the first question you ask yourself? Is it upper motor neuron? Is it lower motor neuron? If it's lower motor neuron, the whole face will be gone. If it's upper motor neuron, only the lower part of the face will be gone. Why, Ramai? Why is that? Because the upper part of the face has a dual innervation. Continuing on lower motor neuron, now we need to find out where the lesion is along this pathway. Is it in the pons? If it's in the pons, the sixth nerve should be involved. Also, the corticospinal tracts, the cerebellar pathway should be involved. Coming out of the pons, it enters the CP angle. In the CP angle, the fifth nerve is there, the eighth nerve is there. So a lesion at that area will cause seventh nerve palsy, eighth nerve palsy, and fifth nerve palsy. And also the basal size, cerebellar size. It extends into the cerebellum. So write that down as well. Then the seventh and the eighth nerves enter the petrous temporal bone, giving off two important branches, nerve to stapedius and nerve to cauda tympani. And then comes out, also gives off the geniculate ganglia. A lesion at the geniculate ganglia causes Ramsay-Hunt syndrome, and you will see vesicles in the ear. The facial nerve comes out of the stylomastoid foramen. Inflammation there causes isolated seventh nerve palsy, and that is called Bell's palsy. And finally, the facial nerve branches in the parotid gland, and parotid tumors, therefore, or surgeries in that area can cause seventh nerve palsy. Okay. Hi. Now we come to the last one, the last set of cranial nerves. So any questions up to now, please ask on the group. So up to now, we have discussed how to answer these two questions in neurology based on our cranial nerve finding. Where is the lesion? That is localization, lateralization, and what is the lesion? This is based on the pathology. We first talked about visual field defects, how to localize visual field defects. A little introduction on TOSI. Remember, you're going to be taught a little bit more in depth about this when you come to your final year professorial appointments. But at the moment, remember, ptosis could be due to a lesion in the third nerve or its pathway. And the pathway also includes neuromuscular junction and muscle, or the sympathetic plexus chain of nerves. Third nerve palsy, you need to know how to localize a third nerve palsy based on the site of lesion. Could it be in the midbrain? Could it be a compression due to a posterior communicating artery? Or is it a mononeuropathy? Then could it be cavernous sinus lesion, superior orbital fissure lesion, or orbital apex lesion? Sixth nerve palsy, again, similarly, it rises in the pons. So could it be a pontine lesion, right? And then could it be a lesion in the sixth nerve itself, or then beyond that in apex of the petrous temporal bone and beyond, right? Seventh nerve, upper motor neuron versus lower motor neuron. Right. Now, there's a question asked about what you mean by lower cranial nerve. So lower cranial nerves is 7 and downwards. 7 and downwards. Right. Now the last set of cranial nerves are cranial nerves that arise from the bulb. Bulb kiyanne medulla. So the word bulb means medulla. So there are a set of cranial nerves that arise from the medulla. 9, 10 and 12. 11 is a rather complicated nerve because it extends into the spinal cord as well. So we are not going to talk very much about that. But basically you have bulbar cranial nerves. These bulbar cranial nerves. And as I told you, all cranial nerves have an upper motor neuron component and a lower motor neuron component. The upper motor neuron component lesion of these bulbar cranial nerve, that is 9, 10, 12 and also to a certain extent 11, mainly 9, 10 and 12, upper motor හැම cranial nerve එකටම upper motor neuron innervation එකක් තියෙනවා. අපි ඕගොල්ලන්ට undergraduate level එකේ we teach you just the 7 and these nerves only. But remember there are upper motor neuron innervations for all the cranial nerves. Right? What a corticobulbar tracts කියලා කියන word ඉස්සර neuron අපි මතක කරන්න. So the upper motor neuron lesion of these bulbar cranial nerves is called pseudobulbar palsy. And what are the signs of pseudobulbar palsy? A very high-pitched nasal voice, a very small triangular shaped tongue, poorly mobile. They can't put it out. And they can't, it's very difficult for them to move the tongue from side to side. In other words, it is spastic and stiff. Upper motor neuron, we talk about this in detail tomorrow as well. Spasticity is a feature of upper motor neuron lesion. So the tongue is very spastic, it is stiff, cannot move. Similarly, the palate is very spastic and stiff as well. Jaw reflex is brisk. Jaw reflex is brisk. Right? And then, yeah. So now you might ask, jaw reflex trigeminal nerve no, but the trigeminal nerve, there is a nucleus in the medulla as well. So trigeminal, there is a nucleus in the medulla as well. So that is why it is involved, brisk. So a small triangular shaped tongue, spastic tongue, okay, a very nasal, high pitched voice, and a spastic palate, very stiff palate. These are all features of upper motor neuron lesions in these cranial nerves. Similarly, if it's a lower motor neuron type lesion, they get something called bulbar palsy. Bulbar palsy. Okay, lower motor neuron type, bulbar palsy. And lower motor neuron, okay, classical features you will see in these, like tongue wasting, fasciculations, okay. Also palatal weakness, you will see. And bulbar palsy can be, the lesion can be anywhere from the origin of these cranial nerves in the medulla to their output, origin within the brainstem to their output, where it leaves the skull base, okay, leaves the skull base through these various foramina. Okay, and I have given you a set of causes. Base of skull lesions, basal meningitis, nasopharyngeal carcinoma. You get involvement of these cranial nerves as they exit the skull base. Okay. Right. Sindhuddhana with background here. Sorry. Alexa, stop playing.
and down, up and down. The blue on bus go up and down, all through the town. The driver on the bus says move on back, move on back, move on back. The driver on the bus says move on back.
Hi. Various forms of music are coming up, sir. Okay. Right. So, lower motor neuron lesions of these bulbar cranial nerves can be due to a lesion anywhere from the exit of these cranial nerves in the brain stem to the exit from the skull base. And all of these we will relearn when you come to professorial appointments, because we need to show you a case and explain some of the localizations of this, because they can be slightly complicated. For homework, read about this lateral medullary syndrome. Again, is something that you know. Please read about this. This is a lesion in the medulla which involves some of these cranial nerves. Okay, but a lesion anywhere from the medulla to the exit point from the skull can cause lesions of these cranial nerves.
By the way, you can start your day with music.
Okay.
Just say, wake me up to Paw Patrol.
Okay. Okay. Right. So that is it for the day. Okay. Now, Antima tika, you had a lot of musical interludes, so I'll just give me a second again. Baba, can you please go and watch it?
Marshall was right behind them.
I'm doing it!
Marshall didn't notice the seagull until it was too late. She tripped over it, tumbled along the track, and rolled across the finish line.
Can you wait for 5 minutes?
Oh, you're more than good, Marshall.
Can you wait for 5 minutes, please?
Marshall couldn't believe his luck.
Right. Okay. So remember, the lower cranial nerves, especially the 9th, 10th, and 12th cranial nerves, and to some extent the 11th cranial nerve, they arise from the medulla. So medullary lesions, remember I told you all these cranial nerves can have an upper motor neuron component and a lower motor neuron component. All that you know. If there is a lesion of the upper motor neurons leading to these cranial nerves, you get something called pseudobulbar palsy. And this is how you identify pseudobulbar palsy. A very nasal voice, a spastic tongue, spastic palate, and a brisk jaw reflex. If you get a lower motor neuron lesion of these cranial nerves, you get something called bulbar palsy. And there you have wasting of the tongue, fasciculations of the tongue, palatal weakness, and an absent jaw reflex. Okay? And to be very simple, the lesion could be in the medulla, for example, something like lateral medullary syndrome, extending right up to the exit point from the skull base. Skull base eliyata and meninges hill karagan, it goes out of the skull base into various foramina. You can see these various foramina. Ogullara pana kadagana skull එක තියාගෙන ඔකට මේ පාඩංකර එකේ hill and chaurasia, basically you have this hill that were created by him also. He has called various hole names and made that as well. So you have these nerves going into these various holes, and until that point, lesion anywhere along this area can cause a lower motor neuron lesion of these cranial nerves and bulbar palsy. Okay.
The next day, right at the
Fine. So that is it. We have learned on how to identify lesions of these cranial nerves and then
here to find the pups.
how to localize these lesions.
Spider, pup!
Sorry,
Look,
Kapradin.
wait for the tooth fairy left for me.
Alex happily threw his new ball up into the air. The dolphins jumped out of the water.
Okay, so any questions? Right. So today, just to recap what we have done, we have discussed the cranial nerve examination technique. I would specially emphasize and recommend you to practice the visual field examination technique. Same eye level right in front of the patient's face. Bring your finger halfway between yourself and the patient. Right. Then eye movement examination. Okay. Okay. Then all the cranial nerves you need to okay. So you have to decide where the lesion is, where the localization and the lateralization, and what is the lesion, that is a pathology of the lesion. These are extremely important to identify. So we went through visual field defects, ptosis, third nerve palsy, the course of the third nerve, how you localize lesions along the third nerve, right? Various points. Sixth nerve palsy, where you localize a lesion, various points again. Facial nerve, approach to upper motor neuron versus a lower motor neuron facial nerve palsy. And then finally, just an introduction about these lower cranial nerves, which can be complex. And I'm not going to discuss them in detail now, because you have a little bit of time. When you come to your professorials, I will discuss this in more detail. At the moment, just remember pseudobulbar palsy, bulbar palsy. Pseudobulbar palsy is upper motor neuron innervation problem of these cranial nerves. Bulbar palsy is a lower motor neuron problem. And the lesion could be anywhere from the nuclei of these nerves right up to the exit points and the sort of course of these cranial nerves. Any questions? Piyumi, you say that we need to differentiate, specifically differentiate. There is no way to specifically differentiate
There's no Paw Patrol.
lower motor neuron lesions of the 9th, 10th, and 12th. There are no, you can't,
Patrol.
I'll come and put it on for you. Okay, right? So there is no, you can't specifically a nerve එක අයින් කර කර වෙන වෙනම බලන්න බෑ. So you always ඔක්කොම යන්නේ එකට වගේ තමයි. ඔක්කොම යන්නේ එකට වගේ තමයි. So you can't specifically isolate the action of the nerves. Okay, Piyumi, that's the answer to that question. Right, Hiruni, is there a dual supply to other cranial nerve nuclei from corticobulbar fibers? Yes, Hiruni, there are. So dual innervations, there are dual innervations to certain nuclei. For example, the genioglossus of the tongue, the nucleus is the genioglossus, there is a dual innervation. And there is a dual innervation in the oculomotor nuclear complex to some nuclei. It's a complicated. It's just a facial nerve that you need to know. There are, the answer to your question, yes, there are dual supplies to other cranial nerve nuclei. And for example, one of them is the nerve, the nucleus to the genioglossus of the tongue. And also there are certain nuclei within the third nerve nuclear complex. Because it's rather complicated. Third nerve is a very complicated nucleus. So that also some of those areas have dual innervation. Hari. Sarangan, is that okay?
Yes, sir. That is okay.
Right. Fine. Then I will post this presentation on your Google Classroom. And
Okay.
tomorrow, is there a possibility of doing it a bit early? Ogolonge.
Yeah, sure.
Because I have another meeting at 3 o'clock. Can we do it at Ogolonge Vela having 5:30 like? Is that okay?
5:30? Yes, sir. It should be okay, sir.
Okay, right.
Okay.
Okay.
That's I shall mention.
Right. Okay, I'll send you a message. Right.
Okay.
Hari. Okay. See you tomorrow then.
Thank you, sir.